Welcome to the first episode.
जन जन का रखे ध्यान, जन जन का रखे ध्यान।
Hello, welcome to the first episode of NTB Dialogues in 2025. We at CNS are opening our 15 years old NTB Dialogue series in the new year with positivity and hope. India, with the highest TB burden globally, has recently made a drastic shift to reach the unreached people with the state-of-art free TB services. TB services were free here earlier also, but now a new impetus has been given to the End TB program. The Indian government has launched a 100 days focused campaign from 7 December 2024 till the World TB Day on 24th March 2025 to find the missing TB cases in the most at-risk communities as early as possible. If people with TB are diagnosed correctly and early on, then they can get effective treatment and soon the infection stops spreading from those with TB of the lungs or pulmonary TB as we call it. We have to stop the spread of the infection if we are to end TB. Finding all TB is a critical entry gate to TB treatment and care pathway. India aims to end TB by the end of this year, that is by the end of 2025. So less than 12 months left to deliver on that promise. Every moment counts, and so does every life. We are fortunate to have with us today our old friend, mentor, and guide since decades, Dr. Rajesh Kumar Sood. Based in Dharamshala, Dr. Sood is District TB Officer for Kangra of National TB Elimination Program, and is also the District Program Officer of National Health Mission in Kangra. Kangra is the most populous district of the Indian hilly state of Himachal Pradesh. Dr. Sood has been playing a key role in shaping, building, and strengthening health responses on the front lines for more than 3 decades. Under his leadership, Kangra has got several awards and recognitions for making a big difference in the fight against tuberculosis. Welcome, Dr. Sood. For those of us, yes, Dr. Sood, welcome.
Thank you, Shobha ji, for having me on the CNS, and it's a real pleasure to talk with you and the broader audience through your platform. It's indeed a privilege.
It's a privilege for us. And Doctor, for those of us who may not be fully aware, please can you share what is this 100 days campaign and why is it so important? What are some of the salient features of this campaign?
Well, India has made very commendable progress in TB in terms of decline in incidence, in terms of decline in deaths. But despite all our achievements, much more is needed. So to accelerate the end game, this is a sort of a what you call bullet train in India, which will push the TB campaign much further. An intensified case finding in the high priority districts, and all the persons who are uh, identified as vulnerable, those individuals, they need to be screened and tested for latent TB also. So this is the biggest campaign in the history of India for latent TB, and I think this is the real game changer. I think we will get results in terms of, not in terms of additional TB patients, but in terms of additional load of latent TB which we intend to treat, and that is going to make the shift in the epidemiology of TB a huge dent. We what we want to achieve, the we turn the tap off from where the whole TB comes, the latent TB burden we want to address in such a big manner. So will be a very, very big learning opportunity for everybody in the TB community. uh, TB, latent TB, and in addition, there's differentiated TB care for saving lives. There is nutritional supplements and Nikshay Poshan Yojana. So every component of the TB program is being strengthened and accelerated in a big, big mission mode. I think it's one of the most ambitious programs ever we have seen.
Okay. Many of these things, from what we know, many of these things you have already been doing in your district. But can you please walk us through on how this campaign is being implemented in Kangra? And how is your team finding more TB in key and other vulnerable populations? How do you define those key and vulnerable populations? And how do you identify them? And we'll come to latent TB, yes, later on, which is a very important component to NTB.
You've raised a very pertinent issue. So, how we started it, like the first step was to identify or map the population. So, we have around the what you call the key populations have been grouped into 9 groups. So, first, the traditional group is people who are in the past 5 years have suffered from TB. So, a relapse rate, we expect that in those groups we may find more TB. Then, contacts in the last 2 years among the TB patients. Elderly 60 plus has been the biggest vulnerable population which we have found. Malnourished people, tobacco users, diabetics, people using alcohol, and congregate settings like jails, elderly homes, orphanages, destitute homes, and residential hostels. So these congregate settings are another group. And in the other groups, in the vulnerable populations, it is the tribals, the migrants, cancer patients, the dialysis patient, people on immunosuppressive, COPD patient, asthma patients, drug addicts, hypertensive, anti-TNF treatment, tea garden workers, what you call pregnant women, people who are in the brickins, silicosis, and a new group which is the indoor air pollution. So, lot of women in the households are exposed to the indoor air pollution because of they still burn firewood. So that is another risk group that we have. So it's a huge, huge teamwork. Our team in Kangra, we have 1,800 ashas, around 300 community health officers, our health workers, our treatment supervisors, BMOs, a huge team which worked multiple times to make this mapping possible. This each person was line listed, and then this mapping was finalized. So first step was to do the mapping. I think second step was to build the capacity of all our staff on what this new initiative is. And this is an ongoing process. I think elections in India, we see very good managed exercise. We have 10 rounds of training for the election, 10 rehearsals. But in this program, we don't have 10 rounds of rehearsals. We may have one or two trainings. So still, we keep finding issues that there's people are not able to understand this. People, we need to make repeated times. We need to make uh, have some capacity building. So next 3 days also we are having continuous round of capacity building with our team. So this is a continuous exercise of explaining to everybody how, when, where, what their roles are. So this is another very, very important part. Third part is the logistics. So, and no army can fight a war without logistics. So, getting all the materials in place is a very, very big challenge. So, Central TB Division provides a lot of logistics to us. So, In addition, so local stationery formats, they need to be printed. Like Asha will go house to house, so chalk marking will be done. Markers will be needed. Falcon tubes will be needed. So getting all those logistics and distribution of the logistics to the last point. So we, as managers, we try to procure from the gem, and then we provide to the block teams. The block teams further plan the distribution. They provide to the peripheral teams. So it's a huge, huge effort which goes in into making any campaign successful. Like one of the key things is branding, like visibility of the campaign. It should look like a campaign. So we procured lot of banners with the standardized designs from the central TV division. So, and the banners were displayed in all health institutions, all Ayurvedic health institutions and public places. So it created a atmosphere that people start talking about it. The biggest thing is that people should talk about TB. The HIV, we have been successful because of the open dialogues. And that's so special about your show, that it's the NTB dialogues, because the more we talk about it, the less stigma, the less misconceptions. So, and creating an enabling environment is a very, very important part of it. And in the enabling environment, the biggest part is Jan Bhagedari, which is the community involvement. So support from the administration, support from all the stakeholders. Like just yesterday, we had a big review meeting with chaired by the deputy commissioner, and our innovative team, they developed a 100 days campaign cake to launch the Jan Bhagidari. So we have very, very good team, and they have come up with very, very good ideas to further strengthen this. We have a photo booth where people come and take photographs and share those photographs on social media. One of our colleagues has written a poem on this 100 days campaign to motivate everybody. So it's like a continuous process. Then we have the actual Nikshay Shivers. One, the ASHA worker goes house to house to do the verbal screening. And irrespective of the symptoms, everybody has to get an X-ray done. So here the real challenge comes. In my district, only 18 X-rays are functional, which are uh, and a population of 2.6 lakh vulnerable people. So, and we have one handheld X-ray which was given under CSR by Power Grid Corporation of India. Another, there's an NGO called Tonglen, uh, who have a handheld X-ray, who are collaborating with us. Another is the ICMR project. They have a handheld X-ray. But despite these three equipment, the whole volume of X-rays with the mobile Nikshay Vahan is not more than 3,000 per month. So the X-ray takes time, AI takes some time to read it. So getting so many X-rays actually done is a real challenge, and mobilization is another real challenge. When we do a Nikshay Shivir, when then people come in the village and get their X-rays done. But when there is no mobile X-ray in the village, and we tell the village people to go to the nearby hospital or a faraway hospital to get the X-ray done, the response rate is around 10%. So that's also a very big challenge. I think it's a communication challenge. We need to develop some communication strategies till we have more resources. So that's another area I think we need to work on. So we are starting, and the campaign is just picking up right now. So we don't have outputs right now that so many patients detected or so many TPTs thing, because things have just started moving right now. So that is,
Okay.
I think, the feel on the ground which I get right now.
Okay, thank you. Now, you have talked of X-ray. First of all, what is Nikshay Vahan? Can you explain a little bit more? What is it equipped with, and what are Nikshay Shivers uh, for our uninitiated and for our listeners from abroad? they are camps probably which are
Right.
held, and where and how often are they being held? Can you please explain a little bit more about Nikshay Vahan and Nikshay Shivir?
And also, what is Nikshay?
What is
Yeah.
Nikshay? Yes, right.
So, in Sanskrit, there is a shabd called kshay, which means TB.
Yes.
So, nikshay means not having TB. So, the whole our TB ecosystem is like a nikshay software platform. So, nikshay is the key word in TB. So, nikshay means not having TB. And now the next two words is Nikshe Vahan and Nikshe Shivir. So one mobile van, which usually has a handheld X-ray and is branded with a standard design, which is designed by the central team. And this vehicle goes to some villages where some pre-publicity has been done, and that camp is called the Shivir. So, Nikshay Vahan is the vehicle, basically a branded vehicle which goes, and the slogan is Jan Jan Ka Rakhe Dhyan TB Mukt Bharat Abhiyan. So we care for each and every person, and this TB Mukt Bharat Abhiyan is a definitely a big game changer. So this Vahan is going to go to the remotest villages, and we try to cover villages. And it's very interesting. People, our team moves early in the morning and comes back late in the evening. Very hectic schedules. So they try to do maximum sort of X-rays, and with the X-rays we identify presumptives. So those who are presumptives, they are being offered upfront molecular testing. So our district is fortunate enough to have sufficient NAT machines. So every block has at least one NAT machine. So we are able to provide upfront NAT. Again, in this, we are facing some challenges like our frontline workers. Uh, they got a concept though that we need to have more and more testing. So, in that part, we lost on sample quality, lot of salivary samples. So now we are again emphasizing that there is no target of testing. Only those people who have cough, we'll take samples only from them. And chest x-rays for everybody needs to get a chest x-ray. So let's see how much we are able to get into that. But definitely things have started rolling around now, and like it's a new concept, like you said, that India has taken a new gear. I'll say it's a bullet train for us. And so like people get used to the new bullet train. So that's the feel right now.
Okay. So, how many villages are covered in a day with these Niksha Shivers? Any idea? Any rough idea? They must be
Uh,
being held every day, or what is the frequency?
Right now, all the working days we are doing one Nikshay Shivir.
Okay.
So, till now, around 43 Nikshay Shivers have been held.
Mhm.
And this month again, we are planning another 45 Shivers. So, it's we are trying to run to the most optimal capacities.
Mhm.
Uh, and like these handheld X-rays have a battery. It's a battery operated machine, so that battery needs to be charged. So we do the charging overnight so that next day again we can use that equipment. And that equipment has two batteries, but throughout the day those batteries drain out. So it's we are trying to have maximum utilization of these machines. And like in a day, average is around 70 x-rays in a day.
Okay.
We have had shivers with less, with more. So highest was 199.
Okay.
So depends on the like mobilization, how early we can start, how late we continue. And average, like it's around 70 x-rays a day.
All right. And all these are being done by the handheld X-rays, or as you said, because there are not enough of them, so you are sending them to some health facility also for the X-ray, or
Yes, yes. So that's the another
that?
challenge. So
Yes.
these are the Nikshay Shivers are the ones where we are doing with the
Okay.
mobile van.
Hmm.
But in addition, where we have fixed X-rays, the ASHA workers are mobilizing people to go to the nearest facility. Now
Okay.
here comes the real challenge.
Yes.
In the fixed facility, in my hospital, in a fixed facility, already there is a queue of 100 people who are waiting to get their X-ray done, either advised by the orthopedician or advised by somebody. So the healthy asymptomatic person needs to stand in a queue to get an OPD slip, then another queue to get his prescription done, and then in the third queue to get a zero billing done, and then in the fourth queue to get the X-ray done, and then he is again to go to the doctor to with his report, and so it is a real challenge to get these X-rays done. But our ASHA workers are doing a very good job. The ASHA workers are going along with the patients to the health facilities, making their OPD slips, helping them navigate through the hospital. So it's a very uh, what you call uh, Herculean
Yes.
task for our ASHA workers also to help the patients navigate this whole health system. But they are they're giving their best, and we have our nominal incentives for the ASHAs to mobilize people for the X-rays, nominal incentives for the ASHAs to mobilize them for the Psi-TB testing, which is the latent TB test. But it is the real enthusiasm of the field team rather than the incentives which is driving the whole campaign. So campaign has picked up very well in some blocks. It is picking up in other blocks. So it's a sort of a mixed bag where we are looking at, and I think within this month we aim to achieve full momentum.
Okay. You are screening all of them, asymptomatic also and the symptomatic people also. Is that true?
Definitely. Yeah.
Okay. So there must be challenges in asking an asymptomatic person to go and get an X-ray done or to go and get screened, because
Yes. Yes.
that must be another challenge, and you have to counsel them or whatever way you are making them go for the screening test.
Yeah, so I discussed with my team,
Mm.
and because Ashas don't directly convey their challenges to me, so
Mm, mm,
it is my STS, my BMOs who are more in touch directly with them. So I discussed with my team, and uh, they have reported that during the if you refer them for a nearby facility, response rate is around 5-10% or not more than that.
mm.
But if you do the shiver in the village, response rate is very good. People come. So uh, I think the more outreach we can do, the more handheld machines we have, I think that will be the real game changer. So one of the real thing is the accessibility, and I told you how difficult it is to
Yes.
navigate in the health system. So the person who is sick, he'll still bear with that whole challenge.
Yeah.
But the person who's healthy,
Yes.
asymptomatic, he may give up that is too cumbersome. Let me do it sometime later. And another thing is the real communication challenge.
Mhm.
I think we need to really invest in good quality communication materials for our frontline workers. How to convey this message that latent TB may be there. This is going to create problem for you later. So why not you get tested and have a peace of mind? If there is latent TB, we have medicine. You can be safe for the next 8 years. So it's a very big challenge, I think, and we are learning in the process. I think it's more of a learning right now.
Yes, learning and seeing what are the ground level challenges, rightly so, when you put that campaign into action. And also, you are very right, sir, that if we take the lab to the people, or if we take the testing to the people's door, then obviously we will get more people to be screened. Okay, once the screening is done, what is the next step in the procedure? The supposing those who are found to be presumptive, Then their sputum sample is collected and sent to the nearest lab, or to the, you have TrueNat machines, I believe,
Yeah.
when you want. Yes, yes.
Yes.
So,
So in one of the shivers, we mobilized the TrueNet machine from the lab to the shiver, but we didn't find it very fruitful to actually take it to the shiver, because then my basic services in that hospital get disrupted. So I took a decision that we'll not move TrueNet machines to the shivers. We'll have the samples, and the ashas will transport the samples to the nearest NAT facilities. So upfront NAT is being offered to everybody. Initially, we took a decision that NAT is limited, so let's do microscopy for everybody. And then, but now we have taken a decision that we'll be offering upfront NAT, even if the results take 1 or 2 days later. So that's the better test. So we have sufficient logistics of NAT with us. So we are providing upfront NAT to everybody, and the ashas are the people who are actually transporting the samples from the patient to the NAT facility.
okay. So no microscopy.
Right now, we
No,
are
no. Okay.
avoiding my.
Okay,
Yeah,
that is great, because that is what even the WHO has asked for. I think 2019 they had recommended that there be molecular testing only.
right,
Uh,
right.
all right. And then maybe the results come in 1 or 2 days, and then you start the treatment on the basis of that. So DST is done then. DST is done upfront, which means, is
Yeah,
it?
so with the this molecular testing, we
Hmm.
get the rifampicin resistance
Yes.
upfront. We
Hmm.
send the samples for LPA. There's only one facility for LPA in the whole state. So
Hmm.
after around 1 week or 10 days, we get the LPA results. We
Hmm.
start the person on treatment. We
Hmm.
start his Nikshay Poshan Yojana. He do his comorbidity assessment. We do the differentiated TB care assessment. So differentiated TB care assessment is the very important triaging tool for the saving lives. So anybody who is sick, he needs to be admitted to the hospital. He should not go home. So that is the one thing we are focusing since the last 1 year. So differentiated TB care, at least the baseline assessment we need to ensure, and every TB patient needs to be triaged and given appropriate management. Because the minute we get a person with a chronic kidney disease plus TB, we know it's a very, very high risk
Ah,
of mortality. So,
okay.
management of the comorbidities, management of the adverse drug reactions, these are real challenges. And 5 years ago, our peripheral health institutions, they just used to refer such patients to the medical college. But now people are much more confident in handling cases, and if they don't feel confident, they can do a telemedicine consultation with their nearest specialist. So things are like improving, but still some cases
Yes.
need to travel far. So,
Yes. Yes.
and Nikshay Poshan Yojana, the nutrition support, which is the biggest crowdfunding, the nutrition support by the government has been doubled.
Mm, mm,
So it is now 1,000 per month.
mm,
In addition, the uh, Nikshay Mitra, which is the nutrition support by the community, this is a very good initiative. It's not in terms of nutrition, we don't have too much malnutrition here, but it's more in terms of psychosocial support.
mm,
Somebody at least once a month he's going to take uh, some support, call the patient, give some support to the patient. So that is a very good initiative, I think, and we are working on that initiative also with the persons with TB.
mm,
We have TB Vijitas, the TB champions, the survivors, and
mm.
they are also providing lot of support to the uh, TB persons with TB, as well as the overall enabling environment. So I think once the person is diagnosed, we are trying to this thing improve the patient pathway to the maximum, that the person gets optimal treatment, the best treatment that we can give.
All right. Uh, the molecular test results says they come in 1 or 2 days. LPA will take longer. So you
Yeah.
begin the treatment as soon as the molecular test results come? Do you
Yeah.
begin that
Yep.
immediately the
So
treatment begin?
our
Yes.
our target profile is within 1 week. So
Okay,
maximum
within
within
one
1 week, we
week.
need to
Okay.
start the treatment.
Okay.
Person needs to be consulted. Actually, the diagnosis of TB is a very, very shocking,
Mm,
despite all the advancements, the
mm,
diagnosis of TB is a very, very shocking diagnosis for the patient, the family, and person needs to maybe in denial for a day, then he'll have a second consultation, a third consultation, and then the person will agree. Maybe 50% persons may not have denial, but some patients definitely have a denial, and some patients need more time to accept the diagnosis. So by 1 week we are able to put most of the diagnosed persons on treatment. We have some 1 or 2% people who may still not take
no.
treatment, so that's
Okay.
a challenge.
Yes. Okay. What about those who test negative for presumptive TB in the X-rays or for TB disease in the molecular test? What is the next
So
step for them?
this is the very good step that you picked up. Everybody who doesn't have symptoms
Hmm.
or a molecular test comes negative,
Hmm.
all those will go to the TPT pathway, TB preventive
Acha.
treatment.
Okay.
So everybody is going to be offered the latest skin test, which is called PSI-TB.
Okay.
PSI-TB is a better test than the Montu test which we were using, because it does not interfere with the BCG. We have had a very huge round of adult BCG vaccination, so it is the right time to introduce PSI-TB.
Hmm.
And it has a uniform cutoff of 5 irrespective of all categories. So it's intradermally given, and the induration is measured after 48 to 72 hours. Our staff is trained in the administration. They have been giving BCG vaccine, the Montu test. So PSI-TB testing, whichever people come positive in the PSI-TB, they will be offered the TB preventive treatment, and the treatment that we are giving is 3 HP regimen
Hmm.
for all the people who are TB infection positive. And again, in the cascade, we are facing a challenge here. There's a risk perception among the household context. Traditionally, we were giving TB preventive treatment to the household context. So, the household context, they have a risk perception that we can have the same problem. But among the other vulnerable populations, there is no risk perception. So, the acceptance of TB preventive treatment among these newly diagnosed patients has been low, and it may take some time for them to actually accept TB preventive treatment. So that is another challenge in our cascade. But we are trying to do more and more PSI-TB testing. We are trying to do more and more people who are positive, put them on TBT. And among the people living with HIV, we have started the 1 HP regimen, which is a much shorter and a much better regimen. So that 1 HP is available only for the PLHIV right now. But for the other community, we are using the 3 HP regimen. For the pregnant woman, we are using the 6H regimen.
All right.
INH,
That.
INH
Oh,
only.
okay. Okay. So, and as you said, it'll those who supposing they don't, they've taken the X-ray and they are not presumptive, or they have taken the molecular test and they come out negative. It must be more difficult to convince them to go for a PSI-TB test, because they must be saying that we have already tested negative. So, what is the need of another test? Do you encounter such problems for?
Yeah, definitely. It's a very important issue.
Yes.
And uh, some people do agree, some people don't agree, but we can just tell them that, see, we could not pick anything in this test, so that's why we need another test.
Hmm.
But again, mobilization for is a challenge for the ASHA, because the ASHA has to bring them to the nearest wellness center for administering the PSI-TB. Again, the patient has to come for reading of the PSI-TB. So multiple visits are needed. So definitely there'll be some attrition in the cascade, but we are making all efforts to mobilize more and more people. So our first tranche of PSI-TB supplies has stocked out, and next supplies are in the pipeline. So
Okay.
definitely we are getting a good initial response, and it's too early to evaluate. So it's just
Yes,
like
yes.
the beginning.
Mhm. And all household contacts are being at least offered that test. Like,
Yeah,
yes.
household contacts we were offering since long time, but
Mhm.
it is now that broader community, like we are a vulnerable community. Everybody, every household has elderly population.
Mhm.
Every household has some diabetic, some smoker.
Mhm.
So this campaign should relate to every household in India.
All right. Yes, yes, it actually should. And I also hope that it is, as you said, it should not be 100 days campaign, but it should be an everyday campaign
Right.
till we end tuberculosis, because this should be a continuous process and not just limited to 100 days. We cannot sit back and relax after 100 days. We have
Given
to.
the
Yes,
given the huge targets and the limited resources,
yes,
the this work is going to spill over beyond 100 days, definitely.
yes,
But we are making our best efforts to do whatever best is possible right now. And definitely, you're totally correct that it's not just 100 days, it's 100 days just the first bullet train.
yes,
So
yes,
it should
yes,
carry on and till we achieve the goal of the SDGs ending TB by
yes,
2030.
yes,
And right now, lot of things have received a setback due to COVID.
yes, yes,
All the public health gains are very fragile. So
yes,
we are looking at the SDG goals, and let's see how quick we can achieve them. But definitely we are on the right track, and I think this Jan Bhagedari is one of the biggest strategies where every department, every stakeholder owns up this responsibility that the mining department, the labor department, that we need to get our people checked. We need to give access to the health teams. So just like we did in polio, everybody
yes,
was fully involved. So that level of engagement is coming up. So that is, our youth are doing very, very good work on social media.
mm,
Very, very good creatives by youth. So like we have universities, the universities are joining as Nikshay Mitras. There's one Arni University in Himachal, and they have joined as Nikshay Mitra, which is a very, very good initiative. So youth are joining through open dialogue, and change in mindset is a very, very big thing, I think, which needs to be there, because people still don't have the risk perception that I can have this problem.
yes, yes,
People still think that a person with TB, they need to have separate utensils. So our Central University in Himachal Pradesh, they did a study, and then the campaign focus was that you don't need to have separate utensils because the person becomes non-infectious
yes,
once
yes,
he starts his treatment. You
yes,
need to be scared of the person who is coughing and not getting tested, but you don't need to be scared of the person with TB.
right.
Sometimes, like when we do the Nikshik Mitra kits, nutrition kits distribution, people come with their masks on. So I tell them that please, you don't need to wear masks. The COVID is over right now. So please feel comfortable. So like that scare should not be there. So that
Yes.
scare we need to get addressed.
Uh, but doctor, I have heard, because I do not know, but at least in the cold places and in the hilly areas, masks not only protect, they are not a sign of catching or giving infection, but also protecting from the cold. So it is so cold, and one of my acquaintances, he said he went to Kathmandu and they were all the time wearing masks to protect themselves from the cold. So
Okay.
that could also be that it becomes a part of our lives, like COVID or no COVID, because it will protect us from so many other things, not just infection. Means this is just a thought which came to my mind, that
Yeah.
we can it's we are
Yeah.
protecting ourselves from the cold, not from the it has got nothing to do with TB or anything.
Yeah.
So that is it is really great work you are doing. And as you said, this has to be an everyday affair and continued process. And I would just, you have mentioned a lot many challenges. Could you just list them once again? What are the basic challenges which are being faced? Some, just wrap up of what you have said perhaps in your dialogue today.
Uh,
Yes.
like the first challenge was the apart from the our infrastructure limitations, I think the first challenge was the lack of the role clarity and a hesitancy among our staff. So I think that was an initial challenge which we have tried to address through repeated capacity buildings. Second, mobilization is a challenge, especially where we can't move the Nikshay Vahan because we have only one or two Vahans and huge population, diverse area. And acceptance for TPT, uh, especially in those populations where there's no TB patient as a contact. Uh, like if there is an index case in the household, the risk perception is high. People accept TPT. And another challenge we are facing in monitoring and tracking the whole campaign. The Nikshay software is well designed to take care of all this, but it is overwhelmed with lot of entries. I think the load on the server has gone up 5 times that what I understood. So the server has gone very slow. Manually, it's next to impossible to keep track of the multiple processes that are going on. So we are still trying to develop some strategies like a Google form to have some information on Jan Bhagidari or have some WhatsApp reporting. But eventually, it is the Nikshay platform where we need to have the complete authentic database. So
Yes.
I think that's we hope that that thing is going to stabilize shortly. So these are all teething troubles that we'll get, and sometimes the software goes slow or sometimes it doesn't respond. But all these are temporary issues, and the overall this mood in the TB community is that India has taken a very good,
Yes.
bold, ambitious step, and people are in a what you call the momentum has is going towards this what you call accelerated case finding for not only active TB, also for the latent TB, which is the biggest
Yes.
thing, which is going to be the biggest yield of this thing. And the Jan Bhagidari, the yield from the Jan Bhagidari is not just having this some social media content, but it is going to create the enabling environment which we
Yes.
need so that people don't have a scare of getting tested. Like when we used to prescribe COVID test in those years, 3 years ago, people used to run away from the hospital that
Yes.
we are not going to take treatment here.
Yes.
So
Yes.
still we have challenges in TB testing, a lot of scare. So I think with all these multiple inputs and multiple support, I think we'll definitely move forward. To whatever proportion, I think, but we are definitely going to move forward, I think.
Yes, yes, that is true. With people like you at the helm of affairs, definitely we are going to do that, because managing the team and steering the team in the right direction is very important. And as you said, community participation, what we call Jan Bhagidari, that is community participation, is most important, and also trusting the community,
Right.
because that is what happened in the field of HIV. And who would know it better than you? You have been involved with that also. When you trust the people and just not keep on ordering them or medicalizing the issue, but taking their trust and inputs. That I think will go a long way. And are there any comments or reflections from the audience before we see a few photos of the great work which is being done there? And I was particularly impressed by one photo, which when we show you, I will talk about it. Yes, this is the one which has impressed me most, because for the first time I have seen a female healthcare professional operating the handheld X-ray. All other photographs, maybe others might have seen, but all other photographs I have seen have a man behind it. So great force to women power. And if there are any some other photos to share, we would like to see them. And also any comments or reflections from anyone, because Dr. Sood has said it all and said it so well and explained everything so well to us. Thank you very much for that. Bobby, are we seeing any photos?
Should I share something?
Yes, yes, please do. Some photos are definitely we would like to see.
Uh, this is a glimpse from our launch.
Okay.
We had folk shows, we launched this logo, and we did the handheld X-ray, an
Mm,
exhibition. Another thing I want to show you is specifically we are getting tremendous media support.
mm, mm.
So our friends from the media, they are supporting us like anything. Another thing that I would like to highlight is that we have mobile health teams which routinely go to schools. So
Okay.
we are aligning their work when they go there to the school and the Anganwadi for the health checkup. They also talk about this TB Jan Jan Ka Rakhe Dhyan TB Mukt Bharat
Mm,
Abhiyan.
mm,
Similarly, we have adolescent health counselors, and they go to the schools and do the sessions. So we are trying to join hands with them and integrate TB dialogues into their work. This is some nursing students who have made very nice tattoos and messaging. So wanted to show you this. Again, these are some youth who have made some tattoos. And this is a very favorite picture of mine.
mm.
This is the Diwali diyas, and the
Okay.
youth have made this wonderful message.
Wow, great. NTB. Yes,
Yeah.
yes, yes.
And this NTB dialogues with the Central University of Himachal Pradesh, we did a lot of discussions with the teams. And this is one from the Government Pharmacy College. The last year's theme, Yes, We Can NTB, they've depicted it so nicely.
Mm,
It's
mm.
like the youth power, very, very creative and very,
Yes.
very wonderful. This is another creative way from the village. Our
Mm,
team member went to the Chopal and lot of support generated from the local village. So definitely very, very good and very what you call interesting
think,
creatives come up. And
yes.
this another thing I wanted to show. Our Nikshay Mitra initiative, you see, this is a rising trend. More and more people are joining, so and sustaining, and we are trying to further improve and sustain. So that's another very, very encouraging trend. So I think this is another thing. This is a picture from Jan Bhagidari, where our Ernie University has joined as a Nikshay Mitra.
Mm,
And another thing which I want to show you is this new initiative,
mm.
uh, n- this support to the families. This is
Yes,
a new initiative.
I was about to ask you about that. So that's yes, please tell us about that. Yes.
So basically, nutrition support to the families is a new concept, and what we want to do is that TB is not just an individual disease; it's a more of a family issue, a social issue. So uh, the we prioritize the drug resistant TB patients, and right now around 5 patients who are drug resistant, their families have been given nutrition support through various Nikshay Mitras. So this is one of the good initiative we are like we have been recently able to start. So this is the most recent update from our campaign. So I think this is one of the good things that is also picking up.
Yes, and I
And
think this should be replicated also, because as of now, nutrition is called to be like a vaccine for TB. Good nutrition, like we have had research done in India only on that. That nutrition
right, right.
is a very, very important part.
So nutrition as a vaccine, nutrition as a major tool,
Yes,
and not
yes.
just the nutrition, it's the psychosocial support
Right,
where
right.
the person who feels depressed, isolated, scared, that person gets a confidence. That's the amazing support. Like I'll specially mention Dr. Vinod Paul, Niti Aayog member
Mm,
who hails from Himachal Pradesh,
mm,
and he's also supporting patients.
mm.
So it's like a very, very big leadership from the top down. So it's we are getting people from all walks of life as Nikshay Mitras. And I want to give an example that even our Ashas are supporting Nikshay Mitra. Five Ashas got together in Jwalamukhi and adopted one patient. So that is the level of support we are getting for the persons with TB. So I think that is one of the good things. But again, with the Nikshay Mitra initiative, we can support only those who give their consent,
Yes.
and many people don't give their consent. I think that is the indicator for the stigma, that people who are still scared to talk openly, I think that's another challenge. So we need to work further on that, and I think our universities need to have research on this, that who are these people who don't want to give consent, whether this nutrition supplementation, Niksha Mitra support or NPY support has actually made a difference in the life of those people. So there are a lot of operational researches where I think we need
Yes.
to actually learn from the people, and here the research institutions can come up and help us with this. I think these are areas where we need to work.
Yes, and what you are doing and what the challenges you have mentioned, which you have encountered, I think they need that is an eye opener for other districts and states also, where means not only where the 100 days campaign is going on, but everywhere, pan India, to learn from this and replicate the type of work which you and your team are doing. They others must be doing. Those who are not, I think that's a great inspiration. And that is why I said in the beginning, we are starting this on a very, very positive and hopeful note that it will end well and with the end of tuberculosis. So thank you very
Yeah,
much,
so
Doctor.
just
Yes,
hold on.
yes,
Sorry
yes,
for this. Just wanted to share the Instagram handle of
yes, yes, please. We were
yeah,
wait,
yeah,
we
is
were
right
waiting
here.
for that.
And there are a
Yes.
lot of videos and photo updates on almost on a daily basis, or maybe more than one on every day, which you will find of not only in 100 days, like for Dr. Sood and his team, every day is a NTB day. So they are on
Yes.
a mission, and please follow them on social media and others. And I'll just like to also share that this is a recent study which got published on 3rd of January at
Mm,
Brazil. The cash transfer program has also shown that
mm.
there was a reduction of more than half the number of TB cases and deaths among those living in extreme poverty in indigenous groups. So this is really good that our program is moving in the right direction. Thank you so much, Dr. Sood. We also have amongst us a senior journalist from Zimbabwe, Catherine Murumbedzi. Welcome, Catherine. Thanks a lot for joining in from Zimbabwe. If you have anything to ask, please be welcome. Dr. Sood is right here. India has launched a 100 days campaign in 347 districts to find more TB cases among those who are more at a higher risk of TB. Catherine, over to you if you would like to say anything. Sorry to put you on the spot, Catherine. Welcome. Catherine, Dr. Sood has played
Thank,
a very important role in TB coverage. She is one of the very sincere, committed persons who have been writing on TB, HIV, and other right-based health reporting for maybe more than a decade, at least what we know of her. Catherine, over to you.
thank you, Bobby. Compliments of the new year. And I'm glad to be participating in this important webinar because TB awareness is an everyday thing. It
Yes.
doesn't just wait for 24 March. I'm proud to learn of the strides that India is making. The burden is still high, but there are strides that you're making. For example, the testing of the asymptomatic.
Yes.
Zimbabwe has a study which is being taken by the BRTI at the University of Zimbabwe. It's still in the study phase. They found out that there are lots of cases of people who have TB who are asymptomatic. So I'll be making up a follow-up with Caroline Maposhere, who is heading the study, to find what they have. And I'm pleased to be learning from all of you who are TB grades, TB people. Thank you.
Thank you, Catherine. Thank
Thank
you
you,
for
Kathleen.
your.
Kathleen, perhaps you have joined, you may not have joined when we showed this photo. So Shobha ma'am will tell you, this is a, as you know, this is a handheld X-ray, and this is being used by Dr. Sood's team in mountainous area of Kangra. It's all hills and snow-capped mountains, very beautiful, but very difficult to reach also in terms of health services. So Shobha ma'am, over to you. Sorry for
No, no, no. It's just that this photo has impressed me very much. It once again shows woman power and the involvement of women in the forefront. And Dr. Sood, I would just like, before I end, can you explain something about the ASHA workers again to our audience from abroad? Who are the ASHA
Yeah.
workers?
So, first of all, I'll expand the acronym.
Yes.
ASHA stands for Accredited Social Health Activist. So, the ASHA is a woman of that same village, and average around 1,000 population, which is like her own neighborhood. She caters to that population. Uh, she facilitates basic services for the women like reproductive health, child health care, immunizations, all the basic non-communicable disease screening, mobilization, uh, TB screening, active case finding, and she is given some incentives for this all the work, and which is like performance linked incentives. We can rather say that if you do this work you get this much amount, and in addition the Himachal government has provided some basic minimum salary to them, that it becomes viable for them to work. And these are the real, like, what you call strengths of the health system, because this is the village level outreach of our health system. And uh, they are able to reach to each and every family. I think the ASHA knows every person by name, so that is the strength of the ASHA worker. So, vulnerability mapping, I think nobody knows better than the ASHA worker. Even if we don't have a digital format, I think if we meet the ASHA, she can show us these are the houses where we have people with cancer. These are the houses where we have CKD patients. So she facilitates the healthcare for almost every household, and she's a very key person in the village. So I think that huge army of Asha, they led the resilience in the COVID period. Also, everybody was scared to move out, but these were the people who were going door to door, providing medicines, providing all sorts of support. So I think these are one of the frontline teams. Another frontline teams which I would especially like to mention is the community health officers. We have in India Ayushman Arogya Mandirs, which were earlier called the health and wellness centers. So these are the upgraded sub centers. And a nursing professional is posted there. And in addition to the traditional RCH package, they are providing the NCD package also, and the expanded package of services. And they are very young, computer literate. They are able to update all the data on the portals. So it's a very, very good synergy that the community health officers are able to mentor the ASHAs and build their capacity, handhold them, and together as a team, I think we are able to make a change, make a transition, I think. And we still have challenges. We have HR shortages in some area, but these are the teams. When they will be like universally present, then I think it will be very, very easy for everybody to access healthcare.
Yes. Thank you. And I would just like to add one thing, that the word Asha, it's a Hindi word and it means hope.
Yeah.
So they are our great strength of hope for so many things, as you have said, because they are looking after so many health issues and other issues there. So Asha is the hope, and that is the woman force working at the grassroots level. Thank you.
So
Yes,
it was a
thank
real pleasure talking to
yes.
you, and it is a real eye opener for us also. Your thought-provoking questions will be able to definitely work upon our weaknesses, as well as reflect on what areas for improvement. And definitely, I think the strength comes with collaboration,
Yes.
and just like our local media is being very, very supportive. Your support is also very critical to build the momentum, I think. And I think that's where the NTB dialogues come in. And it's a very, very big step, I think, to support this initiative.
Thank you very much, Doctor. And we are learning at each step from people like you. And we are trying to improve our skills and knowledge and our discerning capacities, that why is this going wrong? What should happen? There are so many things we are learning at each step, and unlearning a lot of things also.
Right, right.
Yes. So thank you very much we were really very, very grateful to Dr. Sood for being here with us today and sharing some of the great work he is doing, and also the challenges which we are facing at the ground level. Thank you.
Thank you, G. And it's a
Thank you.
real team effort. And I think thank you for acknowledging this.